overview of what it is that we look at day to day when we see patients, and the way we have different perspectives on what we do actually in my ways. So it's again to give you an idea of what that looks like. So two quick things. One, I just wanted to thank Christina Murphy, who's sitting back there, for coordinating everything. She's been doing a lot of our support talk this time year, and this has been the best showing we've had actually. And secondly, if you guys have questions, we're happy to answer them. We'll try to get to if you could hold on to them to the end, I'd appreciate it. And if we don't get to your question, or if you remember it when you go home, just please just email, I think, whatever RSVP link you use, and it'll get forwarded. So I am actually going to start by handing it over to Dr. Munson.
Hi, everybody. I do. So if you know me, you know that I love public speaking. So as Megan introduced me, I'm Jennifer Montez. I'm one of the breast surgeons here at Hunterdon. I know a lot of you out there. I see a lot of familiar faces. Thank you for coming tonight. So like Megan said, this is a lot of information. We're going to try to get through it kind of quickly so that we can get to your questions at the end. So I'm sure we've all heard the statistic that one in their lifetime will get breast cancer. And those are pretty scary odds when we think of it. And part of my aim today is to shed some light on how you can evaluate your personal risk. And I know some of you have already been affected by this, but for your family members and people that you know. So breast cancer is a diagnosed cancer in women. It is the second leading cause of cancer death among women, second only to lung cancer. Each year, it's estimated that over 250,000 women in the U.S. will be diagnosed with a breast cancer, and more than 40,000 will die. Breast cancer is a common disease, so it's very important that you know your risk. So the definition of a risk factor is any attribute, characteristic, or exposure of an individual that increases the likelihood of developing a disease. So for example, smoking is obviously a risk factor for lung cancer. Riding a motorcycle is a risk factor for traumatic injury. So this is a comprehensive list of all of the risk factors that there are out there for breast cancer. And I'm sure at some point in my medical schooling, I had to memorize all of them. But the point of this is to show you, and I know that I've had this conversation with some of the audience, that women sit across from me when I'm giving them this news and want to know, why did this happen to me? I do everything right. I eat right. I don't smoke. I'm healthy. This is why. And we're never really going to be able to target one of these and say it's this, but it's a combination of all of the things that we're exposed to, our biology, our genes, and back to risk factors. And the truth is that some of them we just cannot control, but some of them we can. Some things that we can't control are our age, sadly, our gender, age of our first period, age of menopause, your family history, and the genes that were passed on to you from your parents and your ancestors. The things that we can control are our weight, our BMI, how much we exercise, what we choose to put into our bodies as far as eating, smoking, and alcohol. So when it comes to breast cancer, the first and most obvious risk factor is being female. And the vast majority of breast cancers are seen in women. That doesn't mean we don't see them in men. We've treated quite a few men, but obviously we see it more in women. And aging. Breast cancer increases as we age. So again, we talk about the 1 in 8, but in this graph here, these are ages, 20, 30, 40, 50, 60, 70. And this is how many, one and how many. So at 20 years of age, you're going to see one in approximately 1,700. But by the time we hit our 70s, we're talking about 1 in 27. So as we age, it incrementally gets to be a bigger risk factor. Family history is an important risk factor. That being said, it's important to keep in mind that only about 15% of breast cancers are associated with a positive family history. And that's usually something that I say, and a lot of mouths drop open in the audience, because a lot of the time I tell someone they have a breast cancer. No one in my family has had this. Well, 85% of people that have this diagnosis don't have anybody in their family. It's called sporadic. But that being said, when there is a family history, women who have a close blood relative with this disease have a higher risk. So if you have one first-degree relative, meaning your sister, your mother, your daughter, diagnosed with breast cancer, that doubles your risk of having a breast cancer in the future. If you have 2 first-degree relatives that have been diagnosed, that increases your risk 5 times higher than average. So it's important to know what's going on in your family. And for a lot of my patients that I've been meeting, a lot of their relatives have been adopted or they're adopted themselves. And in the past, that used to be kind of a black box of knowing what went on in your family. But now we're able to offer genetic testing, which is a big part of what we do here at Hunterdon in terms of evaluating risk and how best to treat her. So genetic risk factors, again, only about 5 to 10% of breast cancer cases are thought to be hereditary or caused by genetic mutation. The most common is the BRCA1 and BRCA2. This thing does not like me. BRCA1 and BRCA2 are the most common, and that became got a lot of media. As everybody remembers when Angelina Jolie was diagnosed with the BRCA1 mutation, and she chose to have prophylactic mastectomy, meaning have a mastectomy before she had any breast cancer diagnosis to lower her risk of the hospital. And today, there's really in the literature called the Angelina Jolie effect, that after this happened, we saw a significant rise in the number of women getting mastectomy, even though it wasn't necessarily medically necessary, but because of all of the media attention that it got, it's just the trend that we saw in the world of breast cancer management. So a little bit about the CRCA gene. Women who have the BRCA1 mutation or BRCA2 mutation or both have up to an 80% risk of being diagnosed with breast cancer over their lifetime, which is obviously really significant, right? So this is why I've had conversations with patients who say, I knew somebody who had the BRCA gene and they had their breast loss, and I just could not believe they did that over something that hadn't happened yet. When you're talking about an 80% risk of something, that's really significant. And when we're diagnosed, we don't really know what our stage is, if God forbid it has metastasized. So it's really a way for women to take control of the genes that they've developed. The breast cancers associated with the BRCA mutation tend to develop in younger women, and they occur more often in both breast than cancers in women without a genetic mutation. They also have an increased risk for developing ovarian, colon, pancreatic cancers, as well as melanoma. So this is another place where our genetics colleagues come into play, in that we don't like people to just send their genes somewhere and get an answer. We want to know what those genes mean. And our team here is very good about having a comprehensive plan on how to manage patients based on what genetic mutation they might have. And this is just to show again that it's so important to understand that there is a component of family history and genetics at play, that the grand majority of breast cancers are sporadic, meaning they just happen, 85% of them. And this is why it's so important for women to get their screening, despite not having any family members. I've met a lot of people that say, I've never had a mammogram because no one in my family had it. And now we know why it's so important that they do get their screening. Another risk factor for breast cancer is having a history of breast lesions on biopsy. And not all biopsies are malignant, but there are biopsies that come back with atypical results that are known to increase our risk for breast cancer down the line. So papilloma, radial scars, atypical ductal hyperplasia, atypical lobular hyperplasia, lobular carcinoma in situ, PCI shouldn't be honest. But these are lesions that we know increase our risk of breast cancer. And we watch women with these lesions that we find on biopsy in our high-risk team, which we'll talk about more. Sam, our physician assistant extraordinaire, is in the back. She helps manage our high-risk program, where we follow women who we know are at higher risk. Previous chest radiation is another risk factor. These are women who had their chests radiated during childhood or adolescence, usually due to Hodgkin's disease. And this has an extremely high risk of breast cancer. Higher, not higher, but about the same as the BRCA mutation. And we've actually had a couple of patients that have been radiated when they were children and have either been diagnosed with a breast cancer or who we saw as high risk and chose to have prophylactic mastectomy. So the main risk factor for breast cancer, when you boil it down, is exposure to estrogen. And our exposure to estrogen comes in this form, and I'll get into that more as we go. Estrogen stimulates breast growth. Exposure to estrogen over long periods of time without any breaks can increase the risk of breast cancer. That's why when patients come to see me, we ask about whether or not they'd ever had hormonal therapy or estrogen therapy. And again, just like other risk factors, our exposure to estrogen, some of it is in our control and some of it is not. So starting menstruation at a younger age, at age before 12, increases our risk. And going through menopause at a late age after 55 increases our risk. And if you think about it, really that just extends the time that we're exposed to higher amounts of estrogen, right? When we start our period, our estrogen goes up, and when we start menopause, it goes down. So the longer that span is, the longer we're exposed to estrogen. We also get exposed to estrogen in the environment, pesticides and the hormones it needs. And I think that this is going to start to become my soapbox, but I think this is going to start to become a more prevalent topic in the discussion of breast cancers and cancers in general as we go forward, paying attention to what gets put into our food supply and into our environment. So taking combined hormone replacement therapy for several years or more, or taking estrogen alone for more than 10 years has been shown to increase our risk. Being overweight increases our risk and exposure to estrogen. And the reason for that is that once we hit menopause, our primary source of estrogen is our adipose, our fat, because there are enzymes and chemicals in the body that make fat into estrogen, and regularly drinking alcohol. Pregnancy and breastfeeding reduce the overall number of menstrual cycles in a woman's lifetime, and this appears to reduce the risk of breast cancer risk. Women who have never had a full-time pregnancy or have had a full-term pregnancy after the age of 30 have an increased risk. And for women who do have children, breastfeeding can slightly decrease the risk of breast cancer, especially if they breastfeed for 1.5 to 2 years, which if anybody in the room has breastfed, I think breastfeeding for 2 years is a hard act, but it does show you decrease the risk. Alcohol has been clearly linked to an increase in breast cancer. And the reason for that is that it limits our liver's ability to control blood levels of estrogen, which in turn increases our risk. The risk goes up with the amount of alcohol that you drink. So research has shown that having more than 3 alcoholic beverages a week increases the risk of breast cancer by about 15%. No margins. Only some. Obesity. So again, being overweight raises the risk of having breast cancer, especially for women after menopause. Like I just said, that's your primary source of estrogen. I went through that already. So a 5-unit increase in BMI is associated with a 12% increase in the risk of breast cancer. It's significant. And among postmenopausal women, those who are obese have a 20% to 40% increase in developing breast cancer compared to normal weight women. So this has become a really hot topic in the control of recurrence, especially women who have had breast cancer already, in terms of reducing their risk of having a recurrence. Good weight control, good diet, and increasing their exercise. Because lack of exercise, the evidence is growing that exercise can reduce the risk of breast cancer. The American Cancer Society recommends engaging in about 40 to 60 minutes of physical exercise 5 days a week, at least 3 meditation, because that's a lot. And research shows that exercising 4 to 7 hours a week reduces your risk of breast cancer by 15%. So I always kind of joke that if exercising reduces it by 15, maybe you can exercise and actually have that much. So calculating your risk. So who's considered to be at high risk? So by NCCN guidelines, and NCCN is kind of like our cancer Bible, how we decide we manage patients. Anyone with a greater than 20% lifetime risk of getting breast cancer is considered to be at high risk. And if you pull anybody out of the general population, they have about a 12% lifetime risk of having breast cancer. So how do we calculate that risk? And I'm sure some of you have heard me talk about this in the office. We use what's called the HRCC score. And there are multiple online calculators that can be used. We use this one because I think it's the most comprehensive and gives the clearest information. So basically what it is an online calculator algorithm where we put in your current age, your weight, your height, when you started your first period, when you had a child, and at what age. So a lot of the things we talked about with our risk factors, right? These all get plugged into this calculator, and it gives us your lifetime risk. And if it's greater than 20% lifetime risk, you're going to see things because we know that we should be following these women a little bit differently. And what that looked like is they qualified for having a yearly breast MRI along with their yearly mammograms, and these are spread out every 6 months. So that something is looking at the breast every 6 months. An MRI, let's say October, their mammogram in April. So something's looking at them biannually. And then they come into their biannual clinical exam and follow up to see if anything's changed in their family history or anything's going on. And really what that boils down to is early detection. Early detection means smaller cancer, less lymph node involvement, which means less invasive surgery, less treatment, and better survival rates, which is really what it boils down to of what we want. Yeah. Okay.
All right, so we talked a bit about sort of screening, risk factors, and prevention. So what happens when you do get breast cancer, right? So the first step is that sometimes you don't actually have any symptoms of it, right? So which is why screening is so important. In fact, most people don't have symptoms at all. It's you're found to have something abnormal on a mammogram, and then that leads you through the pathway to get a diagnosis and then treatment. If you are somebody who does a self breast exam, and there's a lot of dialogue about whether or not to do self breast exam, but you know your own body. So if you notice things in terms of your skin texture or the nipple, or the most obvious thing is a lump, those are things that you should bring to attention, or bring attention to your primary care physician or your gynecologist. Similarly, your primary care physician or your gynecologist may be doing annual exams, so sometimes it's much attention there. Otherwise, really, it's not screening mammograms. So the things we look at when we look at diagnosing breast cancer are going to be a history review, so symptoms, really it's physical exam. When I say symptoms, there are unfortunately patients who get diagnosed at a later stage of breast cancer where it's metastasized or may have gone to other places in the body, in which case they may have symptoms of the abdominal pain, or because it's in their liver, their sort of breast is in their lungs. So that's much later stages. Imaging, so the dreaded mammogram. So most people should start them at the age of 40. If you have a first degree relative, you choose to start at 35. Ultrasound, so if you have an abnormal mammogram, often the radiologist will recommend that you have an ultrasound, and then also an MRI, also dreaded is what I hear. I'll just tell you guys, I am having my first mammogram next week, so I'll let you know. It's turned 40. So. Biopsy, so the biopsy can either be done by the breast surgeon, sometimes they do them in the office. Yeah, so sometimes they do them in the office. It's also done by radiologists. They're needle biopsies, so they're done usually with local anesthetic. And then other staging scans. So some of you may have had these done before. So we'll often get CAT scans, we'll get a CT scans to look at your abdomen, your pelvis, your chest. We'll get a bone scan to look at the bones. If you've had any sort of like neurologic symptoms, like you tell me you have headaches all the time, you may persistently have headaches, you may get a brain MRI as well. But that's not always standard. So this is just sort of a photo of what the exam looks like, so everybody knows what their breast looks like. Mammogram, so you can see sort of, it's very obvious in this one, but where the abnormality is. Similarly, it's not as obvious on the MRI. I don't have one up of the ultrasound, but these are the sort of the imaging, this is the imaging that we look at, and the importance of the imaging is not only for us to identify where the actual breast lesion is, but also to identify if there's involvement of, let's say, your chest wall, the muscles that are underneath your breast. Is there involvement of any of the lymph nodes? Because that's also important to know. And that also targets where we get biopsied. So this is what a biopsy kind of looks like. But the biopsy, as I mentioned, usually needle biopsy. We usually have sort of a group of pathologists looking at them here through our hospital system. We actually do have, we have a couple of breast pathologists. We often will kind of sit together and go through a case, but usually the sort of process is that you have a breast biopsy, that sample that, just sent in a container is cut into tiny pieces, very thin slices, and a pathologist will look at it under a microscope. It does take several days to come back because we have to stain it for different types of markers. We need to make sure that that tissue, that tumor is actually just coming from the breast and not somewhere else. And they also look for different features of the breast cancer, types of breast cancer, which we'll go into in a minute. Certain types of what we call receptors, which we'll also talk about in a minute. And then they'll also tell us something called grading, which tells us how fast the cells look like they're dividing under a microscope. So again, those are kind of important things that we look at when we're making treatment plans. This kind of on the bottom just kind of looks, so this is like a normal duct in a breast. Ductal hyperplasia and atypical hyperplasia are sort of almost precancerous lesions. And these are kind of things that a pathologist could see under a microscope. DCIS also sort of in between precancerous and cancerous. Some people who have DCIS, we often refer to it as a stage 0 breast cancer. You may have heard it referred to that way. We do treat it often like a stage 1 breast cancer. And then the last slide is invasive ductal carcinoma. The invasive part of it means that it's actually kind of gone through the wall of the actual duct. And when it does that, it actually has the potential to move to other places, right? So it can spread to other parts of your body, to the lymph nodes, to other organs. So this, again, with the pathologist. So this is what they actually look at under a microscope. You couldn't ask me to look at that. I have no idea. That's a nicer, like, circular version of what we kind of look at. But this is the grading that I was talking about. So grade 1 really is when it's really indolent, slow growing. Grade 2 is more intermediate. And grade 3 is really like those cells are really dividing fast. So the cells of that, this could be more effective. So staging in general, there's 4 sort of, well, you can include stage 0, but generally speaking, there's 4 stages. The staging is based on something called the T&M system. The T stands for tumor, so that has to do with the tumor size. N stands for nodes, so how many lymph nodes are involved, and also what the location of the lymph nodes are. And M, so M stands for metastasis. So has it spread to somewhere outside of the local area where the breast and the drainage of the breast, the lymph nodes that's in the breast are. Stage 1, typically a pretty small tumor. Stage 2 is a bigger, slightly bigger tumor. Stage 3, these are rough guidelines. The stage 3 is you have a tumor and you may have some lymph nodes involved. Stage 4 means that it's gone to somewhere else outside of the area. This is a very comprehensive way of us looking at staging, kind of like how she had to memorize risk factors. That's what I did for fellowship, and a lot. So metastatic sites, so that's if you have a stage 4 breast cancer, the most common areas are going to be your liver, lung, bone, and brain. This is just sort of just to show you what we sometimes look at. Not everybody gets a PET scan, but this is something called a PET scan. A PET scan really is a type of scan where you get a sort of a radio-labeled dye. It has sugar on it, and wherever there's cancer cells, it lights up. So that's a good way for us to tell if there's cancer cells somewhere. So in this case, the person has some involvement in the liver. You can actually see if this is the right side. That's like the actual breast mass. So types of breast cancer. So it's based on the actual type, so the tissue type. So the 2 most common are going to be what we call invasive ductal carcinoma and invasive lobular carcinoma. And then you also, the types of breast cancer are based on what we call receptor status. So here, that's the next slide. So there are 3 basic receptors that we look at on a breast cancer cell. So they're like antenna on the breast cancer cell itself. 2 of them are hormones. So estrogen being one of them, and the second one is progesterone. So like Dr. Mons has mentioned, estrogen is a big risk factor for getting breast cancer, and this is a big part of why, because there's antenna on these breast cancer cells that actually take in estrogen, take in progesterone, and actually use it as a food source. So one of the questions I get a lot is that, well, I'm post-menopause. Why do I have hormones? And she mentioned it some previously, but pre-menopause, estrogen hormones are going to come from ovary. Post-menopause, whether it's because of your age or because you've had ovaries taken out, the sort of primary source of estrogen or hormones are going to come from adipose tissue, fat, certain types of fat. And also something called your adrenal glands, which actually secrete sex hormones. So you still have it. You're not in the clear just because we said menopause. The third type of receptor we look at is something called HER2 or HER2. HER2 is a type of protein. It's found on breast cancer cells. We actually see it in other types of cancers as well, but it's another target we look at. So you can get sort of a variation of all of these. You can get a hormone receptor positive, HER2 negative breast cancer. You can get a hormone receptor negative, HER2 positive breast cancer, or you can get something called triple positive breast cancer. So they're all positive, or triple negative breast cancer. Well, none of them are positive. So you put the staging, the tissue type, and the receptor status all together to just really get a specific type of breast cancer, specific diagnosis. So for example, I wrote it here, but a patient may have a stage 3 hormone receptor positive, HER2 negative invasive ductal carcinoma of the right breast, and that would be your diagnosis. This is really important for us to know, especially just as a group, really as a team, because not only does it affect your treatment, what kinds of treatment, but also the sequence of treatment. So we'll get into treatment in just a second. Oh, here it is. That was a second. The treatment of breast cancer. So I would tell patients there's 2 sides to treating breast cancer. So one is the local therapy, which is what these guys do. It's the surgery part of it, taking it out, right? The other part of it, and we don't have our radiation colleagues, so there'll only be one side on radiation. So radiation often is done after a lumpectomy if you just take the tumor out to make sure that things don't grow back in that area. Systemic therapy, which is what I do, and Dr. Bednar, who's in the audience, yawning right now, he's doing right now. I was like, I've heard this before. But systemic therapies are what we call full body therapy, things that actually travel throughout your body. So, and we'll get into a couple of those in a second. The things that are going to go through your blood circulation, through your lymph nodes, so they can travel wherever cells can travel. Systemic therapies are what medical oncologists do. But the goal really is not only, and I also tell this to patients, because I usually see most people post-operatively, and they'll say, well, why do I need more things now? The goal is not to just treat what you have right now, but to make sure that we keep it that way. It's prevention. So that's why there's so many of us. This sort of kind of gives you an idea of how many different pathways we can take in terms of sequencing. This sort of textbook answer is often a patient will have surgery, and then they may have radiation and or systemic therapy. Often though, depending on the stage of cancer or if it's really aggressive, or let's say patients need genetic testing, we may actually do something like chemotherapy first. So during COVID, for example, we actually, because surgery, because the operating rooms were actually closed for quite a while, we actually would put patients on chemotherapy or which I'll go into other types of therapy in that time frame, like almost like a bridge, actually, to keep the treatment up. So I am actually going to hand it back to these guys to talk about surgery, because I don't know what to say. Is this you? Yeah, this is you. And then you have the slides.
She's better at public speaking. No, I need no. Okay. So breast cancer surgical option. The 2 that we can offer are mastectomy and lumpectomy. So mastectomy is when the surgeon removes the entirety of the breast and no muscles are removed from beneath the breast. So this, when mastectomy, if you go back to the history of breast cancer, when it first started being treated, there was something called the Halsted mastectomy, where they would take the whole breast and all of the muscle underneath. It was very aggressive and very deforming. And what we learned looking back is that that really wasn't doing anything beneficial for women. That is pretty much never done anymore. So it's really just removing the breast tissue, and depending on what kind of reconstruction they have or don't have, which Dr. Ibrahim will get into, the skin, the nipple, or sometimes we keep the nipple. We'll get into all of that. Lumpectomy is when we just remove the tumor size, the tumor site or the lump. And some of the normal tissue around it. And the normal tissue that's around it is what we call margin. I'm sure anybody who's had a lumpectomy is familiar with the talk about margin. So when we remove it, we want obviously the whole tumor out. And the way that we are able to make sure that that happens is with normal breast tissue all around it. So the pathologist, when I remove the lump, it looks like a blob of fat really on the table. But the way they look at it is like a cube. So they look at the top, the bottom, and all the fixed side to make sure that there's normal breast tissue. We know that the tumor is inside and nothing has been cut off or left behind. If any of those margins are positive, we do have to go back for a re-excision to clear that margin. That really only happens maybe 1 out of 10 times, maybe less for us, right? 1 out of 20, maybe less. That's what you read in the book. We're that good. So lumpectomy, advantages and disadvantages to either one, right? So the advantage to lumpectomy is that much of the appearance and sensation to the breast is preserved. It's obviously a less invasive surgery and shorter recovery time. You're up and walking that same day, you go home the same day. Some of the disadvantages is that it requires radiation therapy, although some of it is changing now for patients that are older than, I would say, 70. Sometimes they can forego radiation depending on the type of cancer. So that's the thing about breast cancer treatment. It's always in flux, it's always evolving, it's always changing. But for patients who do have radiation, it starts about 6 weeks after surgery. And you see when I wrote this, it was about 6 weeks. Now I say radiation usually lasts about 4. And it does have a bit of a higher risk of local recurrence, meaning that it comes back. Oh, and it requires clear margins. We already talked about that. So mastectomy, some disadvantages. Obviously, it's a more extensive surgery than lumpectomy. There's a longer recovery time, although we've gotten very good at recovery here. We have gotten very good at pain control. We have an ERAP protocol, which Sam has also helped us put together, and Dr. Ibrahim. And really, we've gotten the use of narcotic after mastectomy down very, very minimally. I would say 80 to 90% of our patients aren't taking much narcotic at all. There is a permanent loss of your breath, and sometimes the sensation to the skin. And it may require additional surgery for reconstruction if you choose to do that. Some advantages, there's a lesser chance of local recurrence, which does give women peace of mind. But in anything that's medical, nothing is 100%. Even with mastectomy, women can have recurrence. Oftentimes radiation can be avoided, but not always. And really the only time we would radiate someone after mastectomy is if the lymph nodes were found to be positive, or if the margins were positive, which was very, very rare after mastectomy. So which is better? For women who have a choice, the decision is a very personal one. I often get looked at from across the table and say, what would you do? And the truth is, I'm not really sure what I would do because I haven't been in that position, but my job is to give them all of the information and for them to make the decision for themselves. So part of that decision is, and conversation, is it important to keep your breath as part of your identity? It's very important for women. It's part of sexual enjoyment, but women don't really care at all about that. You want your best cosmetic outcome, the size of your breast versus the size of the area being removed. I have to have this difficult conversation with women who have sometimes a very non-aggressive tumor, but it's large and they have a small breast. And I know that if I do the lumpectomy that I need to do, they're cosmetically going to be unhappy and they would be better served with mastectomy and reconstruction. And then anxiety. There's a lot of anxiety about recurrence. And this is where I tell women that they really have sovereignty over their own body and how they want to move forward. And try to manage part of that anxiety, because really it's not just a myth about making my patient cancer free. I really truly believe that's really part of our biggest part of our job is to maintain quality of life. And part of that quality of life is not constantly ruminating over this.
This is the one lonely radiation slide because they're not here, so too bad. But typically what Dr. Montez mentioned, the radiation protocol, usually it's after surgery, usually wait at least 4 to 6 weeks to have it done. For those of you who had radiation, the way it works is that you meet with them and they do something called simulation or mapping. You may get these tiny tattoos, which you wouldn't even notice. Huh? Are they black light? I should have black. Really? Oh, wow. Pretty cool. But the reason you get tattooed is so that when you are getting radiation, it's daily. The radiation is really just a bunch of beams that are microscopic that are being shot at the breast or the breast tissue, and sometimes at the armpit area where your lymph nodes are. So by having these tattoos, or I guess they use black light now, they can actually confirm that they're hitting that same area at the same points really every day, because we move around, we wiggle, people in our position might change. Typically radiations for 4 weeks, Monday to Friday, about 15 to 20 minutes. We do mostly what we call external beam radiation. That's what's done here on site. We don't really, it's not a brachytherapy, which is like seeds of radiation. We do it some, not as often. And there's something called proton therapy. Sometimes we add for it on TV. There's a proton center that our radiation doctors work with. So in some cases, let's say you're high risk, maybe you've had radiation before, maybe you have heart disease and it's the left-sided breast cancer, and we really need to target just one area to minimize any damage to your heart. Sometimes in those cases, we may consider proton. So that is all they get. Where's this thing? So systemic therapies, there's lots of them, or lots of versions of them. Usually what we think of is chemotherapy, right? So like you've got a chemotherapy, their infusion, they'll give you a lot of symptoms, your skin gets dry, your hair comes out, things like that. So that is a sort of usual version of chemotherapy that we think of. We have what we call immunotherapy. So immunotherapy really uses your own immune system to fight off cancer cells. We don't use it for all types of breast cancer. We don't use it for all stages of breast cancer, but there are certain areas where they're most beneficial. We use what we call endocrine therapy. So some of our patients may be on the awful drugs that you say this for, but they're usually pills, they're tablets. They can vary depending on if you're pre or post menopause. They can vary depending on your tolerance of them. Some of them cause a lot of drinking. Some people, we switch them around sometimes. This is what we often just kind of vaguely refer to as hormone blockers. The idea being that, remember the antenna on the breast cancer cells, trying to reduce that risk. Targeted therapies. So we talked about the BRCA mutation, so the HRCC. We have some therapy for that. Again, it's not for everybody. There are some cases that we have medications that we use for those patients. And then complementary or supportive therapies. And when I say that, I don't just mean therapy themselves, but like people also, right? So physical therapists, oncology rehab here, we have, it's really strong. Our nutritionists, patients will do non-hormonal supplements if they have hot flashes, for example, or acupuncture or mindfulness. Dr. Montez is the founder of Evolve Think, so they do a lot of support groups. So there's a lot of things that go into that. So this is chemo. This is generally what chemo looks like. It can attack literally all the cells in your body. And there are many, many types of chemotherapies, and there are many, many types of regimens. Most patients, barring if you have like aggressive metastatic disease, usually will get some sort of combination of therapies and a varying dosing and frequencies. But really the idea of chemotherapy, and this is why it has side effects, is that it goes after cells that are really dividing fast, which is what cancer cells do. And that's why it affects our skin, our hair, our gut so much, because those are also cells in our body that are really dividing fast. This is a cartoon, I did not draw it, but of what immunotherapy is like. So immunotherapy, a cancer cell is very good at hiding itself. So we're going into Halloween now, but it's almost as if it's wearing a cloak. And what immunotherapy does is almost as if it removes that cloak from that cancer cell. So your immune system knows that, hey, this isn't supposed to be here. Let me go after it. And that's what immunotherapy does. It generally does not have the same side effects that chemotherapy does, not as aggressive in terms of side effects. And if it does have side effects, it's not as common. And generally people have like autoimmune type side effects. And then this is your hormone blocker. So we talked about how you can have these antennae for estrogen and progesterone on your breast cancer cells. These are what they're sort of blocking. There's a drug called tamoxifen. Most people may have heard of it or Googled it to be on it. It's been around for like 60 years. So what it does is it literally goes and sits on top of that receptor so that estrogen can't get into the cell. I don't have a slide. I don't think I have a slide on the targeted therapy or supportive therapy, but it was just a general overview. Do you have slides at the end? Okay, so we have a lot of photos at the end, but Dr. Montez is going to talk about the myths of breast cancer.
There are a lot of myths out there having to do with breast cancer, and this was one that I particularly remember a couple of years ago when Gwyneth Paltrow put out Goop that made me very upset. There was an article that came out about underwires and breast cancer. I was a fellow at the time, and that week we got massive amounts of area calls on exactly what we were talking about earlier, the conversation of how could this have happened to me? I'm still healthy. I do everything right. And now they realize they've been wearing an underwire bath. And there was no truth to this whatsoever. So, and there were actual studies that had to be done to disprove this. So there are a lot of breast cancer myths out there. Who's heard that deodorant can cause breast cancer? A lot of people, right? So there's absolutely no evidence that deodorant can cause breast cancer. They have aluminum, and that has estrogen-like hormonal effects. However, several large studies have failed to show any relationships. In 2017, a survey found that 56% of teenagers believe that antiperspirant can cause breast cancer. That said, if you want to use a aluminum-free deodorant, I do, by all means do that. But there's been no evidence to show that there was any causation. If you have breast pain, you must have breast cancer. True or false? False. But how many times a week do we see breast pain in the hospital? Every day, multiple times. And people are in panic because when something hurts, something is wrong, right? And the truth is that breast pain is really completely normal. Most of the time it's due to just hormonal changes in the body. And there has never really been any research that's shown that women who have breast pain get more breast cancer. That said, I have had women come in who had breast pain and it was something. So if you feel something that's different or weird, by all means, get it checked out. The point of this is just to say it's not often something bad because cancer likes to be sneaky and quiet. I wish it caused pain because then we would catch it quicker. Mammogram cause cancer. I hear this all the time. Have you heard this? Right? And the reason being radiation, right? But the truth is that mammograms save lives. They have decreased the mortality rate, meaning the rate of people dying of breast cancer, by 40% since 1990. That's really significant. So they really are most powerful tool in fighting breast cancer early, really up to 2 to 3 years earlier than something fell on the exam. And skipping a mammogram every other year would miss about 30% of the breast cancer cases that we're diagnosing. And again, the earlier you catch something, the less intervention and the better chance of cure. We know the answer to this one already, right? All breast cancer is genetics. No. So we already talked about this a lot. Only 15 to 20% of breast cancer are people with family history, and only 5 to 10% of people with a gene for the breast cancer. Abortions can cause breast cancer. This was being talked around in my office for a little bit, and there's no linkage between having an abortion and breast cancer. In 2003, the American Congress of Obstetrics and Gynecology found no link, and many other studies have confirmed the same. Men can't get breast cancer. Not true, right? But I've had men in the office for 6 years. It happens to me. Man, we all have breast tissue, man or woman. Their risk is significantly less because they obviously have much less breast tissue. And any man with a breast cancer should be checked for the BRCA gene because they have a higher chance of carrying it. They often sadly present at a later stage of breast cancer because of one, lack of awareness that men aren't going to get mammograms yearly like most do. I'm too old to get breast cancer. We know that this isn't true. The fact is that breast cancer increases exponentially as we age, and that's why getting on mammograms is so very important. So it's important to know your facts, to know your risk, know your risk factors, and make lifestyle changes that can help protect you. The risk factors that we can control to control them. Just get your mammogram. Yeah.
Thank you. I do have a lot of slides, but I'm going to everybody getting up to a point where they can move on with the number of slides. We already talked about breast cancer. Our goal is to cure it. Our goal is to prevent it, but we also want to make sure everything looks good out. That's where our role comes in. So the common problems that we see in breast reconstruction and plastic surgery are Of course, absence of breast, try to reconstruct it. Asymmetric, especially after lumpectomy. You can have it after a one-sided mastectomy, and also a two-sided mastectomy, and also with radiation. Sometimes we see contour deformity, and that can happen both with lumpectomy and mastectomy. With that, we see a lot of post-mastectomy pain. Sometimes it can be treated surgically as well, lymphedema, as well as quality of life issues that we face with breast cancer surgery. A lot of people are getting reconstruction, and that's becoming more common with awareness. And all the October events that we're doing, hopefully people get more awareness. The way human breast is, they are glands and ducts. In a mastectomy, we're going to remove these, and in a lumpectomy, we're going to remove a part of it. And our goal is to try to reconstruct that so it looks from the outside a little bit more proportional and more better. There are a lot of different ways to reconstruct, which can range from your own tissue to implant to a mixture of the two. What most people in the country get at the time of mastectomy is a swing thing, which is a temporary implant that goes right at the time of mastectomy. Not many people love it, but it's temporary, it's going to come out. But the advantage of this is it's a temporary implant which is inflatable and deflatable, so you can get the size right, you can get the shape right, you can also do red to the mastectomy skin at the time of surgery. And also, if somebody is going to need radiation, the radiation is not going to affect their permanent tissue or implant, but just the temporary implant that is going in. It's going to come out and then permanent will go next. In terms of bone tissue, in the old days, people were doing a lot of transplants, which is out of fashion now because it does sacrifice part of muscle. By far, the most common, by 80–90% of the time, if somebody's getting a bone tissue reconstruction, is the CIBT flap, which is named after the vessel that we use without the muscle. I'm going to go through sketches of what that means. And sometimes we add some fat grafting in the end, whether it's bone tissue or implant-based reconstruction, to give it a little bit more natural contour. This is the lenticular flap, which is basically skin and muscle from the back. This is the old school tram flap where people were taking the fixed back muscle from one side and transferring on both sides. It's a two-sided reconstruction, but it does weaken the abdominal wall pretty significantly. There was increases of hernia. Nowadays, we just take the blood vessel and the semen fat and we transplant and reconnect the blood vessel. The pros and cons of the two, and people always talk about that, is mainly the recovery time, the amount of pain, the amount of donor site morbidity, the longer surgery with the deep flap versus an implant is a quicker, shorter surgery, but it has more long-term maintenance. It is kind of a personal decision based on the age, based on risk factors for a major surgery, recovery. Some people don't want to go through a long surgery and long recovery. So there are a lot of different factors that play into this, but at the end of the day, it's a personal decision, unless somebody doesn't have their own tissue to donate from elsewhere. The scar is pretty much same place as the C-section, but it's extended all the way from hip to hip. And that's one of the donor site morbidity because you're getting a scar at another place outside your breast. But it's your own tissue. Some people really want to have a feel of their own tissue in the breast. But there are pros and cons, and we go through it in detail. We look at the breast proportion. We look at whether somebody is going to need radiation, whether somebody has a lot of extra skin, like a weight loss patient, that is going to benefit from having that taken off anyway and reconstructing that, and whether they have any multiple medical conditions, like somebody has heart issues, somebody has blood thinners, somebody has a lot of obesity or not too much of a BMI, meaning somebody BMI of 15 or 20, they will not have enough skin and fat to donate. But somebody with a BMI of say 45 or 50, where there are significant risk factors for certain longer procedures, it's not a good option for them. So a good range is between 30 and 35, and somebody with previous C-section and pregnancy who don't have significant abdominal surgeries where the blood vessels are compromised. So those are the people and people who are going to need radiation, because radiation does cause some changes in the implant that can be problematic for some patients. So if somebody who has small breast, they can have an implant placed directly. But if somebody who has small breast and want to go slightly bigger, they are better served with two-stage reconstruction, where we place tissue expander and then expand it. This is right after surgery. You can see still the band-aid and the redness of the bandage. So it's right like 1 week after the surgery. So they have an option to go bigger size. They try to hide the scar below the breast, so it's not visible, even if they're wearing any swim costume, swim clothes or any. I know the word costume is coming because my kids are going after costume to the Halloween. This is a side view. You can say this patient had small breasts and wanted to go slightly, maybe 1 cup size bigger, so they can have tissue expansion and they can go 1 size bigger. Somebody with bigger breast wants to go smaller, they can also happen the tissue expander. We'll go through. These are all before and after mastectomy. The problem can happen if somebody has nipple that is very low. In that case, if we put in an expander or an implant up here, the nipple will be very low. So this is not a good candidate for nipple sparing unless they have a lift first and then the mastectomy. So if somebody, this is how typically a lift is, so they had a lift first and then now the nipple is smaller in the right position, and then they had expanders there. The band-aids are where the expansion is. How we do that and why we do that is because some patients may have enough time. They have a low-grade tumor. They can wait a couple of months, or they are prophylactic cases like HRCC patients or any patients with family history. They have enough time to go through a lift. So they have a lift done, and then they wait a couple of months. They heal from the lift, and then they have nipple sparing mastectomy from the inframammary fold. So it is technically a 3-stage procedure, but some people have attachment to their nipple areola complex, and they want to preserve that, especially in a prophylactic case where there's no reason to not save it. This is showing the scar for the deep flap. This patient had nipple sparing mastectomy with their own tissue. There's no implant in it. So this is how the scar can be. So people have to be aware of the fact that they can have a scar, which they have to be accepting of the fact that they will have a scar if they want to go for natural tissue reconstruction. This is another patient who didn't have time for a lift, so the nipple is very low. So we can create nipples down the road, and then we can tattoo around it to give them appearance of a nipple complex. Current, this is an old picture. The current day tattoos, especially with the 3D tattoo artists, are much better than this. The other thing I mentioned, we do a lot of surgeries where we have scar in a straight line below the breast. We try to avoid a conventional scar which goes across the chest because it can be visible in the cleavage area. So we're doing a lot of surgeries where the scar is vertical and in the fold. It's easy to hide these scars, so even if they're wearing thin clothes, this can be easily hidden scar. So it's only going to be in the central bone portion of the breast. This is side view of the same picture, and it gives you better ability to appreciate. The nipple is very low. If we had saved her nipple, it would be down here, and it will not look good because the implant or the own tissue is up here. That's why supporters create nipple in the right position then to save their own nipple. And the other reason why we cannot save the nipple is if the tumor is involved in the nipple or it's too close to the nipple, then we're not going to have clear margin if we save the nipple. We don't do reconstruction just for mastectomy. A lot of our reconstructions are actually for lumpectomy. This is just an example of a patient that came to me who had surgery done elsewhere and did not have reconstruction at the time of their lumpectomy. Why she had a huge difference is because when they have tumor taken out from one area of the breast, the radiation is going to shrink it way more because there's the cavity, there's the heat buildup, and also the exposure to the breast cancer is going to be minimal. And sometimes they can have scar in one side of the breast that can pull the nipple to one side when they're having lumpectomy. This is another picture. You can see lumpectomy. Post-lumpectomy, you can see the shrinkage that happens from radiation. A lot of time, patients don't appreciate or are not aware how much the tumor is. can happen after radiation. This patient may not have that huge of a difference right after lumpectomy. But 6 months later, when the radiation has happened and all the changes that happened, they may have a lot of asymmetry. So we do a lot of surgeries for symmetry. We make the other breast smaller, match the two breasts that have similar appearance. This is how lumpectomy reconstruction is at the time of mastectomy. We try to create the scar which is around the areola and straight line down. So it's easily hidden scar. We move the bottom breast up. The tumor is up here. Same scenario, another patient. We lifted the breast up, or a straight line down and around the areola. These are all post-radiation patients. They already have radiation done. We try to make the radiation site slightly bigger, the other side slightly smaller, and over time, and we've done hundreds of these, like we know how we can predict, even though we cannot 100% predict. Sometimes we do need touch-up afterwards, after the radiation. For the other side, we make it slightly more smaller or make one side slightly more. The touch-up is easier than going back in to do surgery in a radiated zone from the scratch. So we do a lot of lumpectomies, lumpectomy reconstruction right at the time of lumpectomy, so we don't have to go back in again. And about 2/3 of these patients don't need any revision surgery. It's done right at the time of lumpectomy. About 1/3 would need a touch-up, which is still going to be much easier than this situation, where they never had any reconstruction at the time of lumpectomy. But not every lumpectomy patient needs a lumpectomy reconstruction. Some people have very small tumor and reasonable size breast volume, and they do not, and their tumor location is such that the scars can be easily hidden, or maybe they don't need any extra high dose radiation. They can just have lumpectomy. But sometimes the lumpectomy patient, especially with a larger tumor or close to the nipple or in the cleavage area, sometimes they benefit significantly if they have lumpectomy reconstruction done right at the time of lumpectomy. It's the side view of the lumpectomy reconstruction, which is difficult to appreciate in the front view. You can see this is a bigger breast, this is a smaller breast. But the breast is round, there's no indentation, nipple is right in the center of the breast. But this patient had lumpectomy reconstruction done. So we lifted this bottom breast up into where the tumor was. So it obliterated the cavity that was there from lumpectomy, gave them nice upper fold forward. Cleavage in the front view that we saw is better. So there are a lot of different advantages aesthetically that they can get. And insurance covers it, both of them, almost all of them. This is another oncoplastic lumpectomy. You can see bottom breast tissue moved up into the top breast. Nipple position is better, even though breast is smaller, but they don't have a fold. They don't have to worry about the redness and the rashes. Another thing we talk about that we've been starting recently is nerve preservation. So in the past, when the folks were in mastectomy, there was no sensation in the nipple. We're trying our best to get some sensation back to the nipple. This is just the view of how many different nerves supply the breast. But the bigger one is the fourth nerve on the side, which is almost giving sensation to half of the nipple areola complex. We try to preserve that and try to reconstruct it back to the nipple. There are a lot of different variation. We go in before mastectomy. We try to preserve the nerve as best as we can. Sometimes we have to go into the breast tissue to harvest some of this nerve. Sometimes it's on the side, which is very few patients, but ideally if we can save it completely, it will be great. But oftentimes we have to reconstruct it. This is just an example. These are the ribs. These nerves come from under the ribs and go to the breast tissue. This is the center, like where the nipple should be. This is the other side, like lateral. This is the fourth rib. This is the fifth rib. So normally the nerves that we see are the fifth rib and the fourth rib that are going into the breast tissue and eventually reaching them. We try to preserve these and then try to reconnect them. That's another example of the same thing. It was a video, but we can't play it. Another thing that we deal with them with the breast cancer is lymphedema, and I'm going to briefly talk about it. It's a very extensive topic. These are different stages of lymphedema from 0 to 3. And there are some surgical treatments that we can do for it. We look for the risk factors that can cause lymphedema. If somebody has full axillary dissection, all lymph nodes taken off, higher risk than death cancer. very low risk for the cancer. Anybody who is having radiation therapy and obesity. These are the three major. There are always minor risk factors too, but these are the three major risk factors we look for. We preemptively select patients. We try to be more aggressive for therapy for those patients. And then sometimes they need surgical treatment, which includes bypass of the lymphatics directly into the vein, either lymph node transfer from different areas, or in advanced stages of lymphedema, we can do liposuction for people in surgeries to reduce the lymph. Last but not the least, a lot of patients after breast cancer surgery can have post-mastectomy pain syndrome, which can be from three common factors that we talk about. One is in the old days, people had implants placed under the muscle. We try to move that pocket from under the muscle to on top of the muscle because most of the time nowadays, when we do reconstruction, we do on top of the muscle. That has much less pain than under the muscle. So this is a procedure like almost every other month. I would have somebody who had implanted 10, 20 years ago. I convert their pocket from under the muscle to on top of the muscle. Capsular contractures are the common cause for pain. We remove the capsule, which is basically scar tissue that builds around the implant, and we change the implant at the same time. So this common term that you will see on Google or elsewhere on the forum is called capsulectomy. That's the procedure for scar tissue. Uroma, regardless of the type of reconstruction, sometimes these nerves, now we are same nerves that we're talking about reconstructing. If people are not careful, they can leave those nerves hanging in there, and sometimes they form nerve balls called neuromas. That neuromas are just a sprouting of nerves. They're trying to grow, but they have nowhere to grow, so they form a ball of nerves, and that can have pinpoint pain, mostly on the side of the breast, like in the outer chest. And those are sometimes treated surgically. A lot of time we give therapy, massage, and other things to break down the scar tissue. Sometimes we send them to interventional pain where they can see these nerves and do some injections to calm down the nerves. And if nothing works, sometimes you have to go in and surgically remove those nerves and bury them deep under the rib. So if you touch them, you can't feel them because they're under the rib. There are a lot of different things we do in breast reconstruction surgery. We do almost every single one of them that we talk about here. Hundreds of surgeries every year that we do in Hunterdon. I started here, I think, in 2017. And I just looked into our case log, and we have done, just myself, not Dr. Montes, like the practices that I'm not involved in, I'm not counting them, but I've done about 15 surgeries there since those years. We have grown our program. When I started, we had about 40 mastectomies that were done in Hunterdon, where our number is 1,200 now. With a lot of catchment in other areas that we're seeing now that people are coming here for treatment. And that does not include the secondary revision surgery or lumpectomies that Dr. Montes is doing herself without my involvement, smaller tumors, early stage tumors. I'm not even involved in those. The those numbers are just very mentioned. But this is an area we focus on. We have pretty extensive breast cancer surgery and reconstruction program, and all other incident services that Dr. Shaw explained before. Almost everything that is in breast surgery, any treatment, form, reconstruction, pain, lymphedema, everything we have done here. That any other bigger or biggest center in the country would do. That's pretty much it. Thank you very much. This is just a small portion of the team. But I like our pictures because those are the pictures that we have.